In the mid-1960s, after passing Medicare and Medicaid legislation, the U.S. Congress thought it would be nice to have consumer groups making decisions on equity, access, and cost. When I got out of the Peace Corps in 1969, I was interested in Southeast Asian studies, international health. Cornell had a great program in Southeast Asian studies. I received a fellowship for 4 years to attend Cornell Community Health Planning Program. I took courses in hospital administration, in health policy, Department of City and Regional Planning, demography, social organization, and change. While at Cornell, I published my first paper in the Journal of Obstetrics and Gynecology. My first job was as director of the City of Boston section for the Health Planning Council for Greater Boston, which is described in my health activist paper on early training in health planning. In the mid-1970s, the federal government, the Public Law 93-641, wrote a detailed community health planning law that called for setting up 4 centers for health planning across the country. One at Boston University. I worked at the BU Center for Health Planning for 4 years, helping the 6 state health planning programs in New England and the 14 regional health planning agencies developed in the New England Health System's plans. In the 1980s, I worked for the federal government, Health and Human Services, responsible for the health planning programs in New Hampshire, Maine, and Rhode Island. I was laid off in Ronald Reagan's reduction in force. I had then applied for a job I've been working for 10 years to get, Executive Director of the Health Planning Council for Greater Boston. The first thing I did was meet the existing board of directors and develop a plan to build up the board and find out their priorities. The health planning law required that the board had a consumer majority. I went out and met every board member in their homes, office, or in my office. We eventually developed an impressive board. The next stage was to meet with the staff that already existed. Individually over a week, I had 4 staff persons with the equivalent of a master's degree. One staff member had a master's degree in public health from the Harvard School of Public Health. We had a person who oversaw communications and other responsibilities for data, and 2 great secretaries. I had another worker with a master's degree in a health planning agency to do a lot of the administration work, which I preferred not to spend a lot of time on. I also hired my former employee at the Boston University Center for Health Planning. I found out there were 6 major corporations in Boston that were concerned with the cost of health care. Some of the companies were key members of the Massachusetts Business Roundtable, such as the New England Telephone Company, Raytheon, Wang, Digital Equipment, corporations in Prime Computer. I called each of these companies and they showed no interest in the Health Planning Council for Greater Boston. I decided to contact the Senate chairman of the Joint House and Senate Health Committee in the Massachusetts legislature, Ed Burke from Framingham. I met with Senator Burke and told him of the $300 million that hospitals were planning to spend in new contracts, adding $300 million to the new annual costs in Massachusetts. He asked me what could be done. I told him about the Certificate of Need program, that they would need to get the approval of the state's Public Health Council. He asked me if I could come back with him in 3 days to the State House and talk with a group. I returned to the State House meeting room with 20 business leaders. Senator Burke introduced me to the group as someone concerned with health costs that they should be working with. The meeting went well with good questions. At the end of the meeting, a representative of the New England Telephone Company approached me and apologized that he never took or returned my 5 calls to him. He wanted to set up a meeting. I slowly met with a lot of the major companies that were interested in health costs, including the Mass Business Roundtable and the Associated Industries of Mass. The Mass Business Roundtable had a staff person who was a graduate of the Harvard School of Public Health and was a friend of one of my staff persons named Beth, who also was a graduate of the Harvard School of Public Health. The Business Roundtable leaders wanted the Health Planning Council for Greater Boston to be their data gathering and analysis partner for many of the projects we had planned. They were very supportive of many of our Certificate of Need projects and our work on health insurance for self-funded employees. Organized labor was a very powerful group in Boston. It was very concerned with health costs on a national level. I knew nobody in labor except for a former employee in a job 10 years before. Lloyd was a distinguished black former union president of the United Auto Workers who built automobiles in Framingham, Mass. In the early 80s. I hired Lloyd to take me around to meet other union leaders in Massachusetts. We would meet with 2 leaders a week. He introduced me to a Jesuit priest who had a business master's degree and was the director of the Labor Guild, an organization set up by the Archdiocese of Boston to bring labor and management together to study. Father Boyle asked me if I could teach a class on health cost containment. I did this class for 7 years for about 20 people each class. We got to meet a lot of labor union leaders through this teaching. We invited the AFL-CIO in Washington to come to Boston to talk about what the unions could do about containing health costs. They agreed to come up and set up whether they're top experts who worked with the U.S. Congress and the executive branch to impact costs. We asked if they could mention the Health Planning Council of Greater Boston in their speeches to all 100 union members. They advised all of the unions to work with the Health Planning Council for Greater Boston. They advised us to set up a labor steering committee to work with the unions. The labor steering committee set up and met monthly for 8 years with a group of 30 unions, and we became close with building trade unions such as the plumbers, painters, laborers, operating engineers, bricklayers, electrical workers, IBEW, and the Teamsters, the United Food and Commercial Workers. One of the first major efforts we made at the Health Planning Council for Greater Boston was the state of Massachusetts Determination of Need, Certificate of Need program. The State Public Health Council voted to review hospitals, nursing home proposals to build new beds or expand services, or to approve or disapprove new technologies. Our agency offered comments to the Public Health Council. We would review as many as 50 proposed projects twice a year. We would review a dozen or so projects that our limited staff could handle. The Mass General would often test new technologies, such as a computer tomographic scanner, CT scanner. They would ask for approval of new technologies so they could be reimbursed. Lithotripter. The lithotripter would send ultrasonic beams into the body, kidney and bladder, and crush stones that would be excreted in urine and not need technology. My staff went with the founders of the lithotripter and learned all about the technology as they did other technologies. Did we need more lithotripters? What hospitals should they be in? These were some of the questions explored. One of our staff persons told me the Health Planning Council of Greater Boston was featured on the famous public broadcast show, the McNeil-Lehrer Report. Former Wellesley Congresswoman Margaret Heckler was the new secretary of HEW. She was interviewed on this national program. She announced the new technology, the lithotripter, was just approved by the Food and Drug Administration. A new technology, and according to studies by, guess who? The Health Planning Council of Greater Boston. The next day, Health Planning Council of Greater Boston got hundreds of calls from people wanting to learn about the lithotripter. Health Planning Council got a certificate of need from 4 Boston teaching hospitals who wanted to begin doing heart transplants at the same time. Other cities had started doing heart transplants earlier. We called the other teaching hospitals in other cities and asking their advice, would they give to us, should we start 4 heart transplant programs at this time? They all suggested starting with 1 program, building up the expertise, then expand to 2 to 3, etc. The surgery was straightforward, they said. You need to have experienced staff who could recognize a tissue rejection or other problems in the middle of the night. You need to have good volume and experience to do this. We recommended starting one hospital, then adding more as the numbers increased. The hospitals had powerful political friends. They got 4 hospitals against our recommendations. The first year of the hospitals, one hospital had a 50% mortality rate, not the expected 5% mortality rate. We were disappointed. One major certificate of aid proved deadly to the Health Planning Council of Greater Boston. Federal government stopped funding regional health planning agencies in the mid-1970s. Massachusetts continued to fund regional health planning agencies. In the late 70s, a major Boston hospital moved to the Boston suburbs and wanted to add expensive teaching hospital beds into the suburban areas, which would be much more expensive than the local community hospital beds. We asked them to coordinate use with the local community hospitals beds, which were much less expensive. They didn't accept our advice. We voted against their expansion of beds. I got a call from a major power in the Massachusetts Senate who told me in a 5-minute call how much he supported the expensive hospitals. I told him that I agreed it was a great hospital. I just wanted the hospital to work with the local community hospitals and use their beds. A few weeks later, I found out that all of the support for community health planning in the Massachusetts legislature had been killed in the state Senate. That was the end of Health Planning Council of Greater Boston. I had to lay off all of my staff, find a new job at the end of the 70s. The ending of Health Planning Council for Greater Boston was caused by a state senator over a hospital dispute. This led to my establishing, with my friend Greg Bulger, a new company, Healthcare Value Management. In the mid-1970s, I attended a lecture by Dr. Jack Wenberg, MD, of Dartmouth College, where he described a database he had worked on in Vermont and later in Maine. The Maine physician studied variations in hospital use in various parts of Maine with physician groups. I worked with a group in the Mass Public Health Association to get the new Commissioner of Health in Massachusetts, Jonathan Fielding, to get federal support to develop a Uniform Hospital Discharge Abstract, UHDDS. The Massachusetts Health Data Consortium was established to maintain the data. I was an active member of the Mass Health Data Council's Board of Directors for at least 10 years. I attended the Health Planning Council of Greater Boston. I wanted them to begin doing small area variation, SAV, studies in Massachusetts. I went up to Dartmouth in Hanover, New Hampshire, to talk to Dr. Wenberg. He gave me a set of slides to explain the method of epidemiology and warned me that physicians in Massachusetts were hostile to his work. Wenberg had attended 9 meetings by organized medicine. One of the physicians who attacked him was a professor emeritus in surgery at the Harvard Medical School and president of the Mass Health Data Consortium, where I was an officer. The Health Planning Council started doing small area variations studies in Mass. At the board meeting on Mass Health Data Consortium, would occasionally ask by the president what he thought about the small area variation studies being done at the Mass Health Data Consortium database. He said that the work of the Health Planning Council of Greater Boston was first rate, but the work of Dr. Wenberg was not real science. The board would shake their heads knowing that they are the same thing. Health Planning Council did a study of 5 years of data on all the cities and towns in Massachusetts and all the 15 neighborhoods in Boston. Dr. Ben Barnes, a college friend of Elliot Richardson, in the article. We submitted the article to the Journal of the American Medical Association. They not only published our article, but they did an editorial on our article encouraging doctors to do similar studies and study whether the high rates were too high and whether the low rates were too low. When it was published in July 3rd, 1985, In JAMA, it was a front page story in the Boston Globe and on television stations in Boston. We had a press conference. At the head table were Bayless Walker, Commissioner of Health of Massachusetts, Benjamin Barnes, who wrote the article for us, Phil Caper, an aide to Senator Kennedy, me and my board president, the president of the Mass College of Surgeons, Dr. Wenberg, Dan Hanley from Maine, who was studying the data in Maine. The program had Franny Moore, Health Data Consortium, Greg Bulger, AFL-CIO, Susan Mercure, Mass Business Roundtable. The article, by permission of JAMA, was published in a report in the Yugoslavian Medical Journal in 1986. The work of the College of Surgeons, the Academy of Pediatrics, the College of Obstetrics and Gynecology. We went to the College of Surgeons in Massachusetts and asked them to work with us to get these small area variation data out to the hospitals and physician groups. They became hesitant at first because we were a consumer group and not under their control. We were polite and explained clearly what epidemiology was, something they never learned about in medical school. The Health Planning Council of Greater Boston and some of the medical groups, surgery, obstetrics, pediatrics, kept getting data out. For example, after working with the College of Surgeons for 6 years, they thanked us for working with them. They did not want to work with a consumer group, but after they did, they were glad they did. They described our methodology as the velvet fist. You were polite, but we knew you were going to do it anyway. We became friends with many hospital medical staff in Concord and Waltham and other hospitals. We also published articles in the American Journal of Obstetrics and Gynecology, 73, 88, 93, the Journal of the American Medical Association in 85, Business and Health in 87, the Archives of Pediatrics and Adolescent Medicine, 95, the Yugoslavian Medical Journal in 86. The Health Planning Council of Greater Boston published over 6 articles in medical journals. A leader of a Boston teaching hospital informed me, and the Health Planning Council of Greater Boston board president, that we was on a national committee that would spend money to replace health planning agencies. He was on the national panel of the AFL-CIO, CAO, Business Roundtable, American Medical Association, American Hospital Association. A Boston group was formed to get new money to Boston and replace the Health Planning Council of Greater Boston. The new organization did not know what they were going to do. They suggested that organizations submit requests for proposals and set up a committee to choose. The Health Planning Council of Greater Boston submitted a proposal, quote, to study physician practice patterns and change them when appropriate. The review group in Boston strongly supported the Health Planning Council of Greater Boston proposal. The National American Medical Association strongly objected and contacted the Mass Medical Society and asked them what they thought of this Health Planning Council Greater Boston proposal. The Mass Medical Society said they did not strongly object. The AMA said that that was the nicest thing the Mass Medical Society ever said because they were already working with the College of Surgeons and other specialty groups. We got the funding and continued our work. When the Health Planning Council of Greater Boston met with the Massachusetts pediatric groups, you needed to study hospital data to understand the high and low rates. They felt the inner city kids would have the high rates and the suburbs the low rates. The rates were almost the reverse. We got a grant from the major Massachusetts business to study the hospital data. We chose 4 large community hospitals and found large teaching hospitals and their pediatric staffs. Our nurses reviewers looked at the data from the 4 city neighborhoods and 4 suburbs, suburban towns that used the teaching hospitals. The results were later published in an article, Variations in Pediatric Pneumonia and Bronchitis, Asthma Admission Rates, Archives of Pediatric and Adolescent Medicine, February 1995. Articles published in medical journals on hysterectomies, cesarean births, prematurity. The third major area the Health Planning Council for Greater Boston worked in was working with self-funded unions and corporate employers. Health insurance costs. We first taught a night course at the Labor Guild School for Industrial Relations. I would teach a weekly 1-hour class once a year for 5 years. One time we had a judge from the American Arbitration Association who was judging health cost problems between management and labor. The Health Planning Council eventually set up a labor steering committee that began to meet monthly at the Plumbers Hall in Dorchester, over 30 unions gathering, mostly self-insured building trade unions. We would get all the unions together to develop a request for proposals, submitted it together to top providers, then review it together. We included 30 unions and 66 corporations. All of our groups were self-insured unions. Some corporations were invited. They were self-insured. Building a trade union would have 4 union members and 4 company owners, 2 administrators. The plumbers union, for example, would have 4 of their union members and 4 owners of the plumbing companies on the board of their trust funds that managed their health plan, life insurance, annuities for the union. Union members, business owners, and administrators of the trust funds were the members of our group. The questions for third-party administrators were: what is the fee to pay a claim per member? How long does it take you to pay a bill? Do you offer other services such as utilization review? Reinsurance. The question has reinsurance companies, what are the fees per insured for 1,000 union members, for bills over 50,000, 100,000, etc. Education. Do you offer any services to reduce the union members and their families? And diet, exercise, disease prevention. How much is that service per month? Group purchasing. Do you do any group purchases to pay for your members? Pharmacy. Do you get any discounts for your members with the pharmacy benefit? Management, pharmacy benefit managers. An RFP was sent out to the top third-party administrators in the country, as well as to companies offering individual services. We asked for responses from each of our 36 groups. The Mass Citizens Roundtable later asked us to do the same process for them as did the state of Maine. We would meet every week at the Plumbers Hall to review, as a group, the responses to any questions we had. We would ask for responses. Once we finished the review, we invited the TPAs and other corporations to come to the meetings, one company in the morning, one in the afternoon, for further questioning. After this review, the unions were on their own in any follow-up. We met with one union that hired a nurse with a background in utilization review. She had worked with a group of doctors who were asked to review hospital data. She attended the first meeting to take an exam to become a board-certified physician utilization review. When she told them she was a nurse, they told her this was only for doctors. She had done all the work for the doctors and threatened to sue them. They let her take the exam. She passed, the only board-certified nurse in the country. She worked for the union and gave advice on other options for surgeries and gave help in discharge planning. We also learned from the same union that they had a pharmacist. The pharmacist told me that he bought a pill for his union for 8 cents. It cost 80 cents at a CVS pharmacy. The union pharmacist was also on the board of the Massachusetts Pharmacy Commission. The union asked for a discount. They got it for their union pharmacy. We also learned from a third-party administrator in other parts of the country that they got discounts from hospitals and physician groups because of their size. Our unions asked us if we could maybe in the future consider doing some group purchasing. It was an idea that led us to setting up healthcare value management in the future.